Welcome back. Thanks for joining us today for Neuroelectrics webinar. My name is Rafał Nowak and I will be your host today. So today we will cover very interesting topic and related to the phrase time is brain. So we're going to talk about bringing stroke treatment to the patients using a mobile stroke unit. We'll be talking about the implementation of mobile stroke units with extended capabilities into the routine emergency medical service. And I'm very happy and honored to welcome our guest speaker. We are honored to have today with us Professor Silke Walters. Hi, Silke.
Hello. Thank you for the invitation.
Good to have you here, Silke. So please let me quickly introduce Professor Silke Walter. She's a consultant neurologist with additional training in neurological intensive care and prehospital emergency medicine at the Department of Neurology, Saarland University in Germany. She holds honorary positions with the East of England Ambulance Service NHS Trust and the East Suffolk on North Essex NHS Foundation Trust in Ipswich Hospital. She's the chief investigator for the Advanced Mobile Stroke Unit trial. Professor Walter has a broad research portfolio with experience in clinical and basic science research. She was involved actually in the implementation of the first mobile stroke unit ambulance for pre-hospital stroke care in 2008 and performed the first outside hospital acute stroke intravenous thrombolysis. So she has been actively working in this field since then. She's passionate about improving acute stroke care involving the different healthcare professionals participating in patient journey and has worked as a principal investigator in various clinical research projects. She also holds editorial board positions with various journals, is involved in the guidelines working groups for the European Stroke Organization, and works as a chair of the European Stroke Organization Clinical Trial Network Committee. So welcome, Silke. Thank you very much for joining us today, and the stage is yours.
Thank you very much also for this very kind introduction. It's my great pleasure to speak about hybrid mobile stroke unit today. Let me just share my slides. So the topic is mobile stroke units for pre-hospital care of acute patients. I do not say stroke patients now, and you will hear in some minutes why this ambulance was initially called mobile stroke unit, but we can do much more than only treating stroke patients. Just to start off with my disclosures, the actual real disclosure is that I'm actively working on mobile stroke units. That is certainly something, and my passion for mobile stroke units is certainly something to consider. Just some introductory information. Medicine is evolving in every field. There are very many patients who need immediate treatment. It's very, very clear for patients with major trauma. No one doubts that, not even patients or relatives. It's also very clear for patients with myocardial problems, heart attacks. There are campaigns speaking about the necessity of immediate treatment for patients with sepsis and also stroke. It's less well known for patients with seizure and status epilepticus. Especially the public is not very aware that all of these and many more actually diseases are very, very time critical. What's the problem then? We know that as clinicians, we know that. What's the problem? The actual problem is that it's really difficult to triage patients in the pre-hospital setting to the right center, to the right level of care. Ambulance diagnostic equipment, also pre-hospital clinician education is limited in a certain way, to a certain extent. They always state themselves as jack of all trades. So it's really tricky to have specialized and specialists out there to identify patients who need a specialist treatment in comprehensive centers. What we know from publications, from the literature, is that approximately 40% of patients who get transferred to hospital actually do not need hospital intervention, which is an important number because all hospitals are stretched, especially emergency departments, which is also illustrated by the time people spend in emergency departments until they get seen and treated, which increases constantly. On the right-hand side, you see an example which I picked from the English NHS Statistical Office. But this is only an example of England, which we know that happens in every country. This then leads to the problem that very often patients come too late for their specialized treatment. And this is now the example stroke, because it's very well investigated and analyzed. And this is very unfortunate because actually we could treat stroke. In stroke, as in other diseases, time is brain. And you can see on the left-hand side here, this nice graphic very clearly illustrating that the longer it takes from symptom onset to treatment, which is illustrated on the x-axis, the lower is the chance to survive with no disability. And in this graphic, no disability is here given with the modified ranking score 0 to 1. And just for those who are not very familiar, it's a very common score used in stroke research. Modified ranking score is quite an easy score, which is 0 is no symptoms at all, 6 would be death, and it more or less categorizes the patients need to walk. That is the main factor which is assessed by the modified ranking score. It's very understandable, though, that patients treated later have a lower chance for an excellent clinical outcome, because when you look to the right-hand side of the screen and you see that per minute untreated stroke, we lose 2 million neurons, of course it can't be good to wait. Unfortunately, only about 1% of patients receive their intravenous thrombolysis, the clotbuster medication, to treat patients with ischemic stroke within the first 60 minutes, within the golden hour after symptom onset, which is very sad, because this is the term golden hour we've stolen from trauma medicine. This is the time symptom onset to treatment within 60 minutes, which is known to be beneficial in trauma, but also in stroke. Of course, the quicker, the better, but quicker than 60 minutes is quite challenging, especially considering this very low number, which we have at the moment anyway. With this problem in mind, in 2003, a neurologist called Klaus Fassbender invented the idea of a mobile stroke unit. And this idea was just very simple. Instead of taking the patient to hospital, why do we not take the hospital to the patient? And he designed an ambulance equipped with a CT scanner, with point-of-care blood testing machines and telemedicine connection to hospital, with the aim to then have also hospital specialists connected to this ambulance via telemedicine if that was needed. The concept was, and if you please concentrate on the lower part of this slide, on this reddish area, the idea is to stabilize patients at the emergency site as usual, but also to diagnose them, start therapy with intravenous thrombolysis, and triage them to the necessary, individually necessary level of care, meaning triaging them to either the next stroke unit or to a comprehensive stroke center where specialized treatment like intraarterial thrombectomy treatment for patients with large vessel occlusion strokes, so strokes caused by a very large blood clot occluding their arteries, where this can happen. And this was then compared in very many studies, then compared to conventional management, which is what we all know. Pre-hospital emergency medical service stabilizes the patient, decides what kind of working diagnosis this might be, and then transfers the patient usually, very often, to the next available hospital, or in the case of stroke, it would be, and that's the guideline, to the next stroke center. In case, this conventional pathway, in case of a large vessel occlusion stroke or a large hemorrhage, then this patient needed secondary transfer to a comprehensive center, and this is very easy to imagine, needs time and needs money. Actually, that's also quite expensive. In 2008, we have the first mobile stroke unit on the road, and you can see this ambulance in the right upper corner and also the inside on this photo on the left-hand side. From the very first moment on, it was very clear, and it's been that clear for every MSU ambulance and service that it's much quicker. In the right lower corner, you can see this graphic showing you the symptom onset to treatment decision time to know what that patient needs. And you can see that 57% of MSU patients got their treatment decision within the first 60 minutes, this golden hour, this important, as quick as possible treatment window, compared to only 4% of the control patients. And what is important to know here in this study, the control group was not just a normal control group. It was a control group set up in the way we know from trauma rooms, from trauma centers. So ambulance crews pre-alerted the patients to the hospital, then neuroradiologists and neurologists, whole teams were waiting in this CT scanner room for this patient, and then more or less everyone jumped onto the patient to make it as quick as possible. And still only 4% of the patients managed to get their treatment decision within 60 minutes. On the left-hand side, in the left lower corner, you can see some images of the CT scanners which are used in mobile stroke units. They have changed a bit. The photo above is an older version. They are a bit smaller now. Most of the mobile stroke units use quite small scanners. You can do non-contrast CT scans to differentiate between ischemic stroke or any brain pathology and, of course, hemorrhagic stroke. And you can do intracranial CT angiography. Intracranial only because this scanner borehole is quite small, which means everything that goes in through this borehole can be scanned, but neck is sometimes quite tricky because patients who are a bit wider, their shoulders actually will not fit into this borehole. And we can do a limited CT perfusion imaging. Limited because the scanner most MSUs use are either 8 or 16 slice scanners, which then translate to quite a limited perfusion capability. And most ambulances are equipped with AI technology like eAspects to help in analyzing the damaged brains. The concept has spread, so there are very many centers now worldwide using mobile stroke units for their pre-hospital management. And there are more. This map is from 2018 and gets updated at the moment. There are very many centers in the USA. There are several in Europe. There is, interestingly, one center in Nigeria, which is not on this map. There are some centers in Asia. Thailand, for example, has not only 2, but 8 mobile stroke units now. You can see one in Melbourne, Australia. There will be a second one in some months in Melbourne, Australia, and there is one in Sydney. So it's expanding, this idea. And I hope you will see in some minutes and will understand why. To give you an idea of how these ambulances look like, I've collected all these photos here. You see they all look a bit different. And actually this is quite good because they have to be integrated into the local systems. So it wouldn't make any sense to have just one single unit, which then was used in every area and every country, every continent. This wouldn't make sense. It wouldn't work. So implementation into the local system is needed for a successful service, which means it must be adjusted. There are some ambulances, you might see that, which look absolutely like normal ambulances, just other stickers on the outside, which also means they have a very normal size. And this is possible, this is feasible. The bigger ones, many of these are from the USA. They've got some wider streets, so that's possible for them to travel with these larger vehicles. And you can see the one on the right-hand side, third row from the top. This is a larger one which carries a full body scanner, so not only a scanner which does the brain analysis, but a full body scanner, and this is why it's quite a big one. there has been extensive research in this field, and there are several studies which have shown how beneficial a mobile stroke unit service for stroke patients could be. And there was a systematic meta-analysis just a while ago, which summarized the data available from all these studies. And you can see that all these studies together, emergency call to thrombolysis to stroke intravenous treatment, was favored when patients were treated with a mobile stroke unit. It was much quicker. And also more patients received treatment. At the moment, treatment rates vary between, IV thrombolysis rates vary between 2 and optimal would be 30%, they vary between 2 and, let's say, 15-20%. The 30% we aim for, they are just nearly not possible. And luckily, good for our patients, what these studies also showed, and this meta-analysis, that more patients could be treated within the golden hour, and mobile stroke unit management in the pre-hospital setting gave the patients a greater chance to be treated within 60 minutes. And again, this translates to a much, much better outcome. And outcome, of course, is the main aim of why we are doing that. And this is summarized in this plot here. You can see mobile stroke unit is on the right-hand side, favors MSU. Data comes from 5 studies, and very clearly, these studies favor clinical outcome of patients treated with a mobile stroke unit. And here again is shown no disability, so modified ranking score of 0 to 1, and 1 would be just minor symptoms realized in a neurological examination, but not realized by a patient. So excellent results, which then was translated and prompted several societies like the European Stroke Organization and the Australian Stroke Society to implement mobile stroke units into their guidelines. And they now suggest mobile stroke unit pre-hospital care for optimization of patient management. Well, so far, so good. And now we come to the evidence, where does it come from? So all these studies were actually conducted in larger cities, in metropoles, in urban areas, clearly urban areas. And what do we have there? We've got many patients. It is very unclear how beneficial it would be in rural areas with fewer patients. When we speak about that, everyone usually immediately says it must be perfect because, of course, very true, and this is actually very correct, it takes a long time to travel to the patient, and it would take a long time for the patient to travel back to hospital. But we also have to keep in mind that with fewer patients, cost-effectiveness, a cost-effective implementation of this concept might be quite challenging. What we also have to keep in mind, and what we don't know, is in these large cities and metropoles, these studies, the mobile stroke units, usually most of them, operated together with normal ambulances. And why did they do that? Because they had so many stroke calls per day that they actually rendezvoused with normal ambulances at the patient side. In case this was not a stroke, they left scene and the normal ambulance crew took over. In case it was a stroke, the mobile stroke unit team took over and the normal ambulance left. In rural areas, there are fewer ambulances, so very likely this wouldn't be feasible. There are not enough ambulances to join and rendezvous with the mobile stroke unit. So this is unclear. And this problem, or this lack of evidence, prompted us to investigate the rural setting. And with these expected lower numbers of stroke patients, we extended our equipment and extended the concept to a hybrid mobile stroke unit. And you can see on the slide that we still have all our normal mobile stroke unit equipment. So there is a small CT scanner, but now there's also mobile X-ray, there's ultrasound, there is quite a huge laboratory unit, which can analyze full blood count, coagulation parameters, kidney parameters, electrolytes, cardiac enzymes, and inflammatory markers. So that is all possible. Telemedicine connection per hospital as before in mobile stroke units, which is quite useful. And also we've upgraded with ECG as part of the normal ambulance equipment anyway, but also with an EEG to do to analyze some brain activity if needed. And what was the aim, or what is still the aim of this project? The aim is to not only treat stroke patients in these rural areas, that state, but also to treat patients with headache, treat patients with sepsis, patients with unconsciousness. Usually it's quite difficult to figure out what the underlying problem is, and also to offer treatment to patients with seizures, and especially, of course, to patients with quick treatment to patients with status epilepticus. I would like to introduce now the first results of a pilot phase of a currently still running randomized trial. So the randomized trial was then developed after a pilot phase, which helped us to understand feasibility of this hybrid mobile stroke unit with extended equipment. And this is a cohort study of 250 participants. They were our pilot participants, if I may call them like that. And we operate this ambulance in a rural area in the east of England. And to the initial dispatch code stroke, we added dispatch codes for patients with unconsciousness, patients with headache, patients with seizures, and patients with fall on their head. Now you might question why fall on their head, that's a trauma. They anyway need hospital treatment. Yes, if it's a major trauma, that's very correct. But what we actually find quite useful in reality, now that we've investigated that a bit, very many older patients in nursing homes have falls on head, or have falls in general, and sometimes hit their head when they fall. And if they are on an anticoagulation, they need to get taken to hospital. They need to get dragged to hospital, more or less, for a CT scan to rule out a subdural hemorrhage. And this can be quite stressful for these patients because they have to travel to a very foreign surrounding. It's usually quite busy in emergency departments. They have to wait. They don't get their regular medication at the right time. They have different food, different people around them. So after some hours, they very, very often get transported back because CT scans very often are clear. And they are unfortunately quite stressed by that. And there are publications that's very clear that it's not beneficial for these elderly patients, especially with pre-existing dementia. The aim of this study was to identify, and this is in the right lower corner, whether the patient needs primary care, needs care in the secondary care level of hospitals, or specialized therapy in comprehensive centers, so tertiary care. And what we can provide, or what we have provided and still do in this ambulance, is we have added additional treatment, not only additional diagnostic equipment, also additional treatment. Stroke thrombolysis clearly state, but also secondary stroke prophylaxis can be initiated on this ambulance. Anticonvulsive treatment with levetiracetam is the anticonvulsant of our choice because it's very easy to administer. There are different types of antibiotics to initiate also sepsis treatment. And we've got a special nebulizer for patients with breathing problems. In this pie chart, you see that these are the results from the 250 pilot patients. 46% could be managed at home, actually, and 40% could be transferred directly to their target ward, which were either medical wards, neurological wards, or stroke units. And 14% needed ED. So that is a reduced number, which was either not stable enough or which stayed completely unclear with all the equipment. So they were then transferred to ED. And when you concentrate on this large table on the right-hand side, please, you can see that the first column is the final hospital diagnosis, discharge diagnosis. or final medical diagnosis in case they were not admitted. Then the second column shows you the dispatch codes. And this makes it clear immediately, dispatch is a big potpourri. So when you look at ischemic strokes, patients with headache, chest pain had a final diagnosis of stroke. When you concentrate on seizures, this is the 1, 2, 3, 4th line. You see that also patients with breathing problems or suspected stroke were final seizure patients. So dispatch is a major problem in all pre-hospital studies. And for stroke, numbers are well investigated. It's quite clear that stroke dispatch usually has an accuracy of 30% only. All right, when we see the results from patients with falls, you can see that they were 27, and interestingly, the majority of these patients could be managed in the community, meaning these were exactly these patients I described earlier, fall on head on anticoagulation. They only needed to go in for a CT scan to rule out a subdural hemorrhage. And this was quite a beneficial result of this initial pilot phase. And when we concentrate on patients who needed anticonvulsants or presented with seizures, you can see that in the treatment column, the 4th column of this table, highlighted in red now, that patients who needed anticonvulsive treatment, they actually not only were diagnosed with seizure as main diagnosis, but also interestingly, we had 2 patients with ischemic stroke. One of them got thrombolized, and they both had a clear ischemic stroke, who had an early onset of seizure, which was quite interesting. Of course, we had 16 patients with final diagnosis of seizure. Patients with intracranial hemorrhage can present with seizures. There was one who needed anticonvulsive treatment, and also other neurological, meaning brain metastasis, and other medical patients needed anticonvulsive treatment. So it was quite common. With our seizure patients, and they were 16, we actually, not only with them, or in general, our diagnostic pathway was that each and every time we did not really understand the situation, or we suspected that there could be an epileptic activity as underlying explanation for the presenting symptoms, we performed an EEG. We never performed an EEG if we could see active epileptic motor activity, because it was clear then. In the 16 patients who presented with a final diagnosis of seizure, 4 had, interestingly, a status non-convulsive. And I found this very interesting because these patients, they usually get picked up very delayed. They are just, we all know that, they are just unresponsive. They are slower, they are just not their normal selves. And by doing a very quick EEG, and I've just, when we prepared this presentation just some minutes ago, I said it's very easy to conduct this EEG. It's a very limited analysis with 8 leads, but it's very easy to conduct that in the pre-hospital setting. And we operate with 2 people only on the back of the ambulance, and it's absolutely no problem to integrate that in our patient treatment and management. So 4 patients with status, 11 patients with first symptomatic seizure, and 1 patient had a known epilepsy. And there is one example of the quality we get with our 8 leads of one of these quite poorly patients in the lower right corner. We've chosen an 8-lead EEG because our aim is to say status yes or no. This is what we need to know in the emergency situation. When we now see who needed anticonvulsive treatment, they were 15 patients, and 2 of them, I've mentioned that already, were ischemic stroke patients, 1 patient with intracranial hemorrhage. 8 patients had seizures after stroke, so brain damage, brain previously damaged by stroke. There was 1 patient with a known diagnosis of epilepsy, 1 patient with a new diagnosis of intracerebral metastasis, which we diagnosed by scanning his brain before. And there were also 2 patients with medical background, with 1 with very severe hyponatremia and combined with sepsis, and 1 patient after a hypoxic brain damage after cardiac arrest. And now what I find quite nice to know is the mean time from emergency call to treatment with levetiracetam in those 15 patients treated was 53 minutes. And when we compare this to what we know from the literature, this was only a pilot phase, so we don't have a real and randomized control group. That is what we conduct at the moment. When we compare this to the literature, there is a publication by a group from America. They say that the mean delay of pre-hospital benzodiazepine treatment is 1 hour and 10 minutes. And we all know that benzodiazepine treatment can do something good, but sometimes this is just not enough. And when we now consider the International League Against Epilepsy headline, motto, or emphasis, time is brain, especially when treating a status epilepticus, I think this is probably a new idea and a new perspective which could be integrated not only in these full mobile stroke unit ambulances, but also in a broader way in the pre-hospital management. Why do we need ultra-early treatments? Because we know that also for patients with epilepsy, it's just better, their outcome is better. Not only their clinical outcome, also their mortality increases by 32% when seizure activity lasts longer than 60 minutes. And this is an information, when you see the reference, this is old. We've known that for decades. And we know that, but what we know now is that patients with clear motor epileptic activity, they are easy to identify. What we do not know, all those patients with non-convulsive brain epileptic activity, when do they get treated? It's quite difficult to pick them up if not everyone gets a routinely assessed with EEG in the emergency situations. This graphic on the right-hand side just illustrates what these numbers I've just mentioned illustrate, that the longer it takes until treatment of the status, the higher is the mortality rate. And there is another very interesting publication, which is only 5 years old, which identified that the cut-off time from onset to specific anti-epileptic treatment, so not benzos, for poor outcome is roughly at 2.5 hours, which means that we have to be much quicker. We really have to identify these patients as quick as possible, and we have to work as quickly as possible. And when you now see these 2.5 hours and consider the time I've just given on the slide before, if I may go back, of 1 hour, 10 minutes median delay in the pre-hospital setting for benzo treatment, you see there is quite some work to do. There are future possibilities which are quite interesting. They are not only dealing with patients, concentrating on patients with known epilepsy or epilepsy in general. There is a Dutch group investigating the possibilities EEG can offer to differentiate patients with large vessel occlusion stroke from those patients with ischemic stroke, which is not a large vessel occlusion, just smaller vessels occluded. And they have just published their emergency department results, and you can see that their sensitivities and specificities for differentiation of large vessel from non-large vessel stroke is actually really good. And what they do at the moment, their whole project was designed as a several stage project. They are now in their stage of assessing the effectiveness in the pre-hospital setting. And hopefully we will hear these results in the next year. Also quite interesting is this systematic review of Shahrastani, published 2 years ago, which also has quite a nice part about EEG, in this case, analyzed for differentiation between acute ischemic stroke from acute hemorrhagic stroke, with a sensitivity of 92%. Very clearly, we would never ever at the moment rely on EEG only when we start thrombolysis. But we also have to be open and see new possibilities and help new technologies and these possibilities to develop so that we can hopefully improve the time until our patients reach these specialists. This is what we want. We want to have the right patient at the right center or with the right team as quickly as possible. To conclude, I think pre-hospital medicine is evolving dramatically, also for patients with neurological diseases. It's very clear now, there's enough evidence that it's highly beneficial to treat ischemic stroke patients in the pre-hospital setting. This does not mean at all that we should not run in hospitals and should not aim to optimize as good as possible, but it could add an additional way or concept of optimizing the management. And also patients with seizures, patients with non-convulsive epilepsy, they are probably not very well in the pre-hospital setting. They are a bit neglected, and I think there lies a huge potential for making their treatment much better and much quicker, much more streamlined. And I would like to conclude with the message that I think we have to feel very, very responsible for the pre-hospital phase as well. Patients, we have to work in teams with the ambulance service, with the emergency medical service, pre-hospital clinicians. Otherwise, if we only concentrate on clinical work, otherwise it's really, really tricky to optimize have a very streamlined pathway for our patients. And with this, I would like to conclude, and I thank you very much for your attention.
Thank you very much, Silke. Really great presentation, and congratulations of the results, implementation of the pilot in the real life settings. We have some time for questions, so you can use the Q&A tool to write the question. And to start with, let me ask like a question from the logistical point of view in terms of mobile stroke unit or hybrid unit. In terms of personnel, what are the needs, or if there are any guidelines actually, how many paramedics or physicians should be included in the?
That's a very, very good question. It's well, there are different concepts. It depends on a bit on where you operate. There are concepts ranging from 2 people on board, and I will explain their educational background in a minute. 2 people on board to 4 or 5. It depends on how much money you've got in where you work, and it depends on how good your telemedicine connection is. So with a very good telemedicine connection and actually network, that is not, it's not the hardware, it's more the network which is available in the area you operate, you can rely on this telemedicine, which means you could have specialists also helping from hospital. They can stay in the hospital and help you. But if you are not really sure, and this is actually what we do at the moment, we staff the ambulance only with 2 people, with 1 paramedic and 1 doctor. But we've got the doctor on board because we operate in very rural areas, and we are not 100% sure and can't be 100% sure to start off with how good our telemedicine connection will be. It does work. It does actually work quite well, but this is part of the study to also assess this. There are centers in America, they have from the first day on started operating this ambulance with a paramedic, a stroke nurse, and a radiology technician. And doctors join by remote access via telemedicine. There is the example from Australia. They staff the ambulance with a doctor, a stroke nurse, a radiographer, so radiologist, technician, and a paramedic. They've got some more people on board. There is an example coming from Norway. They staff their ambulance as they would staff their usual ambulance, which would be either nurse, they've got nurses also working in the pre-hospital setting, or paramedic, and an anesthetist, because anesthetists are the pre-hospital emergency doctors. And in order to enable them to administer stroke thrombolysis. They've got a neurologist connected via telemedicine as well, but anesthetists and also paramedics in Norway, they underwent a very special training to get some additional stroke education. So there are different concepts, and I can say operating with 2 people at the moment, it does work well. I like 3 people because there's quite a lot of work to do, and it's just a bit nicer to have more hands. But it does work brilliantly, and we've got very, very fast treatment times for stroke, also with only 2 people on board.
Okay, thank you. So actually, the European Stroke Organization is working on the guidelines, but depends on the specific particular conditions regarding the staff needs for the ambulance.
Yeah. So the guidelines, what they say about staffing is that all these results, all this evidence we've got from all these mobile stroke unit studies and trials, they were always, they had stroke specialists involved. What the guideline does say is that this expertise is absolutely needed to keep these good outcome results. So there must be a specialist involved, an expert, stroke expert involved. Otherwise, we wouldn't know what happened.
Okay, and you were presenting clear results regarding the cost benefits, and there are obviously very clear results related to reduction of the rehabilitation needs, the long-term costs related to rehabilitation, because you are getting in this gold hour with the treatment for stroke.
Exactly.
But this is for patient, but for cost of the whole investment.
Good question. Yes. So one quality, there are multiple publications, and there will be one important publication coming soon. There are, at the moment, the quality adjusted life years gained. To get one quality adjusted life year, we have to pay roughly 40,000 euros, which is quite a high threshold. But this comes, the calculations are based on 3 to 4 members of staff, and we know that the staffing is the most expensive part.
Okay, you provide the expertise directly to the patient. No,
yeah,
you
exactly.
a neurologist. The neurologist going directly to the
exactly. Yes, exactly. So we need more cost effectiveness analysis. That is very clear. What we've got at the moment, and these numbers, we've got only one study with prospective cost effectiveness analysis. All the other studies are calculations and estimations only. We need more real data.
In terms of the implementation, but from the manufacturer point of view of the ambulance or adaptation of the ambulance, how would this work? Like in Barcelona and Catalonia, we want to implement this. What would be the first step?
Yeah, we would first, I think the first step is always involve your team, and you definitely need to involve the ambulance service. And ambulance people are absolutely fantastic. They know exactly what they need and want to have in the ambulance and where it needs to go. So this would be step number 1. And then actually these ambulances, our ambulance gets built in quite an experienced ambulance builder in the south of Germany. They are very experienced, and they have built more mobile stroke units, so they know exactly what to do and how to build a mobile stroke unit.
How to include CT safety there.
Exactly. It's all tested. It's crash tested. That, of course, it must be crash tested. All the equipment needs to be safe and secure. So that is all done, and they have built several mobile stroke units now.
Okay, thank you. We have some questions here. One is from Aniket. It's from India, and the question is: doctors in India are obsessed with CT and MRI. How can we integrate EEG in the first line?
Yeah, that's a very good question. Actually, I think we would not want to replace EEG, CT or MRI by EEG. But what we found also where we operate at the moment, there wouldn't be an EEG available in the emergency department. But I think what we have to consider is what we know from hospital proper or full diagnostic EEG assessments, they take quite a while, and there are many leads. If we only wanted to answer the question status yes or no, I think we probably, as neurologists, have to step back and be happy with fewer leads, fewer information, with less information, which then can be administered quicker, or can be gained quicker is the better word, which actually means that probably would be feasible in every emergency department. I mean, the Electra Dutch study, they have managed to assess their patients in the emergency department. So it does work.
Okay, so this would be actually the involvement of EEG, but not for stroke. So for the hybrid unit, this would be like something very recommended, but for stroke, we still have CT as a gold standard and differentiation between hemorrhagic and ischemic.
Clearly, yes.
And
I think the EEG, if I may add, I think the EEG at the moment would have its position to diagnose patients with non-convulsive status or non-convulsive seizures mainly. I think this is where it's very, very useful. And I think this is very, very underrepresented in our patient numbers, because it just takes quite long until we then do an EEG in reality. And sometimes this is the disease has changed already, brain activity has changed. So it would be quite good to actually learn a bit more about this quite difficult to diagnose disease.
Okay. There is a question from Ignacio related again to EEG. Are you using EEG just for diagnostics, or have you also considered it for treatment outcome monitoring in the ambulance?
Yeah, so that's an excellent question. We use it for diagnostic purposes, and I've mentioned shortly that we only use it when we do not understand the situation. So in case we see a patient with motor or clear epileptic activity, clinically clear epileptic activity, we don't do an EEG. But in situations in which we didn't really understand what's going on, you get a story, and this story is not very, you can't pinpoint it down to one working hypothesis, then we add an EEG. In case we found a status, what we did is we started intravenous treatment with levetiracetam and kept the EEG running, which means we monitored our treatment success. But we do not use EEG in the way or as other people do. Yeah.
Okay, so it's like if you see that it's non-convulsive epilepsy, or actually status, non-convulsive status, so you can detect and you can monitor then after with introduction of levetiracetam directly in the ambulance.
Yeah.
Okay, we have a question from Walter Potters. Very interesting talk. Impressive how well integrated the mobile strain units are across countries. What are your experience with availability of physical space for EEG or other additional equipment in addition to CT in the ambulance? Actually, this is one of the PIs of the Electra stroke study.
Perfect, fantastic, great, oh wonderful. So hello, nice to speak to you. So it does work. So we've got a very, very small EEG. It's just a tiny little box, and we've got 8 leads, and we operate it with a tablet computer, which you use for other purposes as well. The ambulance is quite narrow. It's everything inside is quite narrow, but the EEG does not add anything really important to that, or it doesn't make it worse. The CT scanner definitely is the biggest part in our ambulance. We've got 2 aisles on either side of the stretcher, in where we can operate and stand and work. And we can actually walk around the stretcher still, even though there is a CT scanner on board. We had some challenges getting the mobile extra units, which I haven't really mentioned because that was part of the pilot trial or study that we don't use that very often. We had some challenges to get this into the ambulance, but at the end we found some space where it could be secured and safe. EEG is no problem at all. So okay, just a tiny box, some leads, and a tablet PC. That is all we need.
Okay, thank you. And yeah, we were focusing a lot on the technical stuff, but I would like to ask you more from socioeconomic point of view regarding if you see the differences in time from the onset of symptoms to the emergency unit call, and actually to the mobile stroke unit call and arrival, in the population with high socioeconomic status and low socioeconomic status, in the populations with the rural and urban areas, if you see in your study, because this is quite important from the equity point of view, actually.
Very good question. We don't know, no data yet. We can't answer that. So we need more studies to answer that. All the evidence we've got comes from countries with high economic background, first world countries, according to the World Bank Index. So we have no results yet from the economic point of view.
Okay. So like in terms of education of patients regarding recognition of stroke or first symptom of stroke, you are getting like a lot of false positive scores too, or there is like a triage in the first step before moving actually the whole team?
Yeah, that's a great question. Thank you for that. So we've got dispatch centers have an accuracy of approximately 30%, which is not high. So you get everything and nothing, and you can't rely on that very much, I must say, and I will come to that again in a second. Patients and relatives who are the first ones to respond to new symptoms, they, I think, do understand, some of them do understand that this might be a stroke, have the idea. Unfortunately, where we operate at the moment, and this could be improved, there is quite a delay between symptom onset and emergency call. And we do see, and this is also published from very many other centers, that especially patients who are a bit older, who have the highest risk factors for stroke, they tend to wait a bit longer. They don't want to bother anyone. They hope that it goes away on its own again. And sometimes, because patients with transient ischemic attacks, TIA patients, symptoms do go away, but sometimes they don't. And then it's very unfortunate because they are quite late in their treatment window. So public awareness campaigns, we've got a lot of data on this. They do last for approximately 6 months, and then you have to redo. You have to re-educate, which more or less means you are busy all the time. Probably there is an interesting study coming from America, from the USA, and they have started educating pupils in school. And this was quite good because they then took this information back to their homes, and they are sometimes, maybe not as 5, 6, 7 or 10-year-olds, but later on they will be adults, and if they get this information early in their life, they might keep it better. But this is still not clear, but this might be a good idea actually. Okay. So public awareness and also dispatch center accuracy needs to be better, clearly, yes.
Okay. Last question from Walter again. How much time does it take EMS personnel to apply and acquire the 8-channel EEG? And on the stroke patients or family complain, or do the stroke patients or family complain about that on-site delay?
Yeah. So it's very quick. I don't have the exact numbers, but it depends a tiny bit on where we apply it, where we start it, whether in the ambulance or in the house. If we do it in the ambulance, everything is very close and next to us. If we have to get it to the patient side, it takes, of course, this walking distance from ambulance to house again. But the actual, and this is what I know, the actual EEG, we have a 5-minute protocol programmed. So this is for us just to say whether it's a status or not, and to set it up, and this is what we've timed as well, takes 6 minutes per patient. Our EMS personnel is super quick with that. We've got, but I have to add is we've got 3 dedicated paramedics to this ambulance, and they do that so often, they just do that as quick as just a bit longer as an EEG would take, 6 minutes, and then it's connected to the tablet computer, it's run. Very, very quick.
Okay.
And patients and relatives, I haven't answered that. Yeah. They actually never complain about that. They are quite grateful for all this additional assessment. And when we do see that something needs to be treated, because we do use this EEG when the situation is very unclear. And when we do that and then can explain that we have found this and that, and this is why we start treatment now here, they're actually very grateful.
Yeah, actually, the answer is you don't have to go direct to the hospital. Hospital came to you.
Yeah,
The
that is
hospital.
true. That's true. I mean, we speak. There's much more hospitals can do, but at least a bit of that assessment. Yeah, that is true.
If you can apply TPA directly on site, and you don't have to go, because yeah, actually you are not going anymore to emergency room with
Yeah,
patients.
that's true.
So you are going.
Yeah, good point. So if we detect it, if we understand the underlying situation, and then we can take patients to the target ward, which is very, very well received by the patients, because queuing in emergency departments is just nothing nice. They prefer going directly to target wards. But of course, you have to understand what's going on, and you have to, if possible, start treatments to stabilize the patient. So that's another benefit. And I think compared to the Electra trial, our aim is to identify whether there is a situation which we need to treat with anti-epileptic treatment, which probably makes it easier to communicate this to patients and relatives.
Sure. Okay. We spent our hour, Silke, with you. Thank you very much. Thank you for the presentation. Thanks for all questions and your answers, Silke. I want to thank everybody also for joining us today. I hope you will join us again for the next webinar at the end of June. You will have Professor Vince Clark talking about brain stimulation methods to improve memory day and night. So please visit our webpage, neuroelastic.com, where we will find more information about upcoming webinars. Thank you, Silke, again. Thank you for everything what you are doing, actually, for the improving time to brain, how we can get actually to our patients, and for all educations from patient's point of view, how to recognize correctly stroke and actually get the treatment on time.
Thank you very much. Thank you for inviting me and for this interesting discussion. Thank you.
Thank you. Thank you very much. See you next time soon. Have a great day.
Bye-bye.
Bye.